Okay, good morning, everyone. Thank you for attending today's webinar entitled Hope for the Best and Prepare for the Worst, a Perinatal Guide to COVID-19. This will be presented by Dr. Michael Ruma, a maternal fetal medicine from the Perinatal Associates of New Mexico. He is the current Vice Chairman of the American College of Obstetrics and Gynecology, District 8, New Mexico. So let's welcome Dr. Michael Ruma.
Thank you very much for having me. I really appreciate the opportunity to speak to you tonight. I hope that we aren't all tired of coronavirus quite yet, but I wanted to take a little opportunity to share with you some of the things that we've learned in our practice and provide you a little bit of what I would say is a perinatal guide to COVID-19. We've done a little welcome. I'm going to give you a lecture and we'll conclude with some questions and answers. I really sincerely appreciate you taking time out of your very busy schedules to spend the afternoon, morning, and evening with us here, depending on what time zone you're on. And I hope that you'll enjoy the lecture. A little bit about myself. I do work for Hologic. I also do work for a company called CCSI, and then have a lot of fun with my friends at Philips Ultrasound, speaking, doing consulting, and a variety of different research efforts for them. I grew up in Omaha, Nebraska, did medical school at Creighton University, my fellowship training in maternal fetal medicine in Chapel Hill, North Carolina, and also have a master's in health policy and administration. And I'm currently the president of the largest perinatal practice in the state of New Mexico, known as Perinatal Associates in New Mexico. We're a private practice. We're founded in 1987. We currently have 4 MFM physicians. We have a lot of team members, over 100 employees. We use a lot of different nurse practitioners, 3 genetics counselors, and we have 30 sonographers. We have 10 offices in the state. Here's just a map representation of the United States. You can see where New Mexico is here in the southwest of the United States. Albuquerque is the biggest city in our state, and this is the 5th largest landmass state in the United States. I wanted to run through in the next hour a bit about, I think we all know COVID-19 and we know coronavirus in these terms, but do we know all of the medical capabilities of this disease? Do we know all of the terminology behind this? I'd like to give us a little more information about the disease. I think it's really important to focus on the medical literature about this topic and then its impact on pregnancy, and then talk to you about how you should be prepared in your own offices on labor and delivery in a variety of different environments to be prepared to tackle the issues that are surrounding COVID-19. This is likely not going away. We need to pay attention to this, and we need to be fully prepared to take on this issue. And then I'd like to end with some of our own successes, strategies on the management of this particular disease and this pandemic. So here's a little bit about the basics of coronavirus and COVID-19. So we know that this was started in December 2019 in Wuhan. This initial novel coronavirus was identified in this particular area, kind of in the southeastern portion of China. The World Health Organization designated the disease COVID-19, or coronavirus disease. And we now know, and this disease has actually been designated the virus causing the disease form of COVID-19. The virus is actually known as SARS-CoV-2, or Severe Acute Respiratory Syndrome Coronavirus 2. As of today, May 18th, 2020, 4.8 million cases have been diagnosed worldwide, with 316,000 deaths, or a death rate globally of around just over 6%. Let's talk a little bit about the virology of this beta coronavirus. It has a subgenus similar to SARS. It's related also to several different coronaviruses that emanate in bats. Whether or not this came from a bat, we're not fully certain of that, but there's certainly some theories behind that. It uses an ACE2 or angiotensin converting enzyme to actually enter our cells, and we're not certain exactly how this was transmitted novelly into humans. First reported in Wuhan, China, December 2019, peaked in Wuhan in February of 2020. A notable substantial decrease was noted in Wuhan in March of 2020. And then in the United States, we now have this in all 50 states and actually in 4 different territories. This virus is absolutely everywhere. It's on every single continent in the world, except for Antarctica. You can see this map from Johns Hopkins University here. The United States, highly affected. South America, affected. Africa, Europe, India, Asia, as we progress into Russia, the former Soviet Union, all throughout Australia. With the limited and no exposure, our scientists, about 40, 50 individuals, are currently waiting out COVID-19 in the dark winter of Antarctica currently, with no cases, fortunately, on that continent. How is this virus transmitted? We know that it's a person-to-person transmission. It occurs with respiratory droplets. It's similar to influenza. Comes in viral droplets that occur during coughing and sneezing and talking. And these little viral droplets, unfortunately, then make their way to our mouth and our nose and our eyes. And they touch a mucous membrane. We think it takes about 1,000 viral particles that actually become infected. And we're now learning that maybe just simply talking loudly may emanate that number of viral particles. But these droplets do not tend to travel more than about 6 feet, and they're only, at least experimentally, they seem to be only detectable in the air for about 3 hours. Whether or not that 3 hours is contagious or not, that's still in question. There's asymptomatic and pre-symptomatic transmission. That's unfortunately the sneaky part of COVID-19, is that most individuals that we're noticing, and the highest likelihood of infection is coming from people that you have no idea they actually have the virus. Our incubation time from exposure to those 1,000 viral particles is a mean of 5 days, meaning from infection or contact with an exposure, on average, most individuals are going to become sick within 5 days. That can happen more rapidly. It can be delayed up to 14 days. And interestingly, your infectiousness might actually be higher in earlier stages of the infection. Our quantity of viral shedding, how much you're exposing other people had you had or do if you have COVID-19, your shedding of the virus actually depends on the severity of your actual illness. If you have a mild illness with no hypoxemia, we know that 90% of those folks are going to have a negative viral swab 10 days after their symptom onset. But if you happen to be one of those individuals that's caring for an ICU COVID positive patient that is hypoxic, that is on a ventilator, that has a severe illness that characterizes severe or critical, interestingly, they remain infectious for much longer. 100% positive viral nasopharyngeal swabs after symptom onset for at least 10 days. So if you're exposed to somebody that has just a mild illness, highly unlikely you're going to contract this virus. If you're exposed to individuals with critical illness in the intensive care unit, definitely want to be wearing appropriate personal protective equipment or PPE. What's the risk of this transmission? People often ask us that question of SARS-CoV-2. So most secondary infections are actually coming from household contacts and within our own healthcare settings, particularly when PPE is not being used appropriately or is not available, just demonstrating the extreme importance of PPE for our essential healthcare workers around the globe. If you just have casual contact, though, with an individual who has COVID-19, your actual chance of getting this viral infection is quite low. And there's 2 studies, one from Korea and another from the United States, that says that that risk is about 1 in 200. So pretty small, that if just casual contact on the sidewalk, going to the grocery store, that you actually interact with somebody that has COVID-19, that you're actually going to contract it from that individual. If you live within the house of a patient with COVID-19, even then, that rate is still not dramatically high, with 7.6% in a Korean study and 10.5% of individuals living with a household member that has coronavirus, only about 1 in 10 chance that they actually contract the virus themselves. So I think that that's some reassuring information that you should be able to share with patients, and just for general knowledge for yourself, provide some confidence for your staff that have to take care of these individuals and are working on the front lines. There's a term called R0. And this has become important, particularly in epidemiology of viral infection. So we talk about R0 as the number of people that an average infected person with coronavirus or any viral infection is going to infect. And we know that that R naught number is about 2 to 2.5 for coronavirus. And you can see that on average, if that patient has COVID-19, they're going to infect up to 2.5 individuals. This virus, COVID-19, SARS-CoV-2, is more contagious than the seasonal flu. Seasonal flu, H1N1, you typically only infect about 1 to 1.5 people. Less contagious than MERS, but definitely almost twice as contagious as the seasonal influenza. There's a variety of clinical features for SARS-CoV-2, and it ranges from very mild, which fortunately happens in the majority of patients. This is all comers here, both pregnant and non-pregnant. About 81% are going to have a mild infection, 14% severe, and critical 5%. So about a 1 in 20 chance that patient that you're interacting with is going to have a critical illness. And fortunately, the fatality rate, at least in these smaller studies, is reported at 2.3%. As you saw from my first slide, though, unfortunately, I think that rate it may be higher at a rate about 6.5%. As we face this disease, there are a variety of risk factors for severe illness. Advancing age is one of them. 49 to 56 years of age tends to be the most likely time when this starts to affect individuals. And as we get older, markedly higher fatality rate, 27-fold higher for patients over the age of 85. And if you happen to have an underlying medical issue like cardiovascular disease or hypertension, diabetes, those individuals definitely have a much higher chance of severe illness. What are some of the clinical manifestations? What does SARS-CoV-2 look like in a patient? So you can understand why patients are being screened for temperatures at the airport, hotels, now in restaurants as we reopen. Fever represented in 99% of patients, at least in this initial study by Wang, presented in the Journal of American Medical Association. Fatigue, 70%, kind of a difficult characteristic or clinical manifestation. I think we're all a bit fatigued after talking so much about coronavirus and being afraid and anxiety and changes in all of our lives. I think we're all a bit fatigued right now. Characteristic also, though, is something to pay attention is dry cough, anorexia, not wanting to eat, myalgias, body ache, shortness of breath, and then interestingly, seems to affect our taste and smell. And as a doctor, I don't recognize too many other diseases that affect our smell and taste. So this is something definitely to be asking patients about as they think about coming into your offices and entering your hospital facilities. Symptoms tend to progress over a week. And I'll tell you, our first interaction with COVID-19 very easily identified in a pregnant woman who came off of a cruise, left on March 8th, came back to the United States on March 15th, and then a few days later, day 3, she had developed a cough. On day 5, she started to have shortness of breath. And within 2 days, our first COVID pregnant patient actually was hospitalized. Fortunately, she did not progress on to acute respiratory distress syndrome, nor did she have an ICU admission. We'll talk about how this affects pregnancy in a little bit. But in general, this is a pretty rapidly progressive disease. Literally within a week, development of symptoms, hospital admission, and if you're going to become ill, very likely on days 8, 9, and 10 of symptom onset, that's the time frame to watch these types of patients. The recovery in most individuals is going to take about 2 weeks. If they have a severe illness, it could take over a month. These are some of the findings on a clinical chest x-ray. 80% are going to have an abnormal chest x-ray. And I encourage you to remember these words, ground glass. You think about that often when you think about respiratory distress syndrome in newborns and preterm babies. But interestingly, for this disease, COVID-19, we're seeing ground glass in adults. And you can see it here along the lungs here, all this kind of hazy gray. That is that ground glass appearance. And it tends to be most noticeable. You're not going to see this on a chest x-ray within 2 days after symptom onset. You're going to see this on days 9, 10, 11, 12 after onset of symptoms. Other things to be aware of. These patients often have abnormal or unusual labs. Leukopenia, not an elevated white count, but actually a suppressed white count. And this is exactly what we saw in our patient, our first COVID positive patient that we interacted with in my practice in March. She had a cough, she had a fever, she had bilateral pneumonia on her chest x-ray, just as this patient did here. And interestingly though, instead of what we might suspect of bacterial or community-acquired pneumonia, she had a white count of 3,000. unusual. And she also had a slightly suppressed platelet count. Don't get too carried away by this and this low platelet count, though, because ultimately the most common thing is symptoms, fever. These labs often may lead us astray when we start to think about COVID as a pregnancy diagnosis in all patients. Here's a few findings that you can see in a COVID-positive chest x-ray. You can see these patchy consolidations in this x-ray here. And here you can begin to see pleural effusions. Perihilar distribution is noted, and again in this image as well. So just a few of the common findings you're going to take away. If you see a radiologist that's telling you on a radiology report, though, that there is bilateral ground glass appearance, think viral pneumonia, think about COVID-19. How do we go about diagnosing this issue? It's made by detection of reverse transcription, polymerase chain reaction, or RT-PCR, which ideally should be done by nasopharyngeal swab. That tends to be the most effective way of obtaining a good specimen. Oropharyngeal swab is not essential, but you do see it being used around the globe. This is something you should talk to your local labs. In the United States, we are solely using nasopharyngeal swabs. A positive test confirms a diagnosis of COVID-19. What do you do with these patients? So you've diagnosed them, they've complained of symptoms, you've brought them into a safe testing site, and now they have a positive RT-PCR on their nasopharyngeal swab. Most of them are going to have a mild infection. I said at least 80% of the general population are going to be mild. Reassure them, home management. Don't encourage them to go anywhere. Talk to them via telemedicine. Discuss their care over the phone. Talk to them significantly about preventing transmission to others. And then monitor them for clinical deterioration, and this is where the telemedicine comes in. Severe infections require hospitalization, unfortunately. Encouraging the patients, telling them that on days 6, 7, 8, 9, if they note significant changes in their breathing, difficulties breathing, this is the time they definitely need to seek hospitalization, oxygenation, and hopefully not, but these patients may need ventilatory support. So that's a little bit about the basics of coronavirus. I want to share a little bit about COVID-19 and pregnancy. I'll tell you, I've been on television a variety of times in my career, but never as frequently about one particular subject, and that's COVID-19. Within the last 30 days, I've been asked to do at least 2 television interviews and talk to the news and issue press releases on this particular topic and how it affects pregnancy. This has struck fear and significant anxiety into all of our pregnant patients around the globe. We have patients now wearing masks wherever they walk around. You have patients and nurses and babies wearing face shields, things that are so uncommon and so unusual. This is an image from Thailand here. Just so unusual and so strikingly different. It causes significant anxiety for patients. What do we know about COVID-19 and pregnancy? So I will tell you that the general approach to these patients when they're pregnant is really no different than that in non-pregnant individuals. Prevention, evaluation, diagnosis, and really the treatment is similar to a non-pregnant person, with the exception that you have a passenger, the unborn child, that you have to pay attention to. In obstetric care, maternal-fetal medicine care, we have 2 patients. You have a mother and her baby, and we have to make unique decisions sometimes. We'll talk a little bit about that as we move on. COVID-19 and pregnancy within our medical literature is growing rapidly. I gave this talk for the first time on April 25th. I put into PubMed, the global search tool for medical literature, 2 words, COVID and pregnancy. And on April 25th, there were a total of 83 articles published in the world about coronavirus and pregnancy. Literally within the last 22 days, 23 days, on May 18th, when I redid this today, put in COVID and pregnancy, there are now 180 articles. There's almost 100 more articles within just a short 3-week time period. We have to pay attention to this. There's a lot of burgeoning information. Please read the literature. It's incredibly important. I'd like to summarize some of the most important studies that are out there. There are a variety of small studies, small case reports, 10 patients, 15 patients, 27 patients, different cities, different countries around the globe. This is from the International Journal of Gynecology and Obstetrics. It combines 33 studies. Amazingly, we don't even have 400 pregnant women with COVID-19 to look at reported in the literature. but I think that this is the largest study to date about pregnancy and coronavirus. On average, patients were 21 to 42 years old. This is an important number. 95.6% of patients have a mild illness. We need to help encourage patients to decrease their anxiety, practice their social distancing, don't give up on all of that. But if they are infected with coronavirus, they're very likely to have a mild infection. But about 4 to 5% of patients will have a severe or critical illness, and those are the individuals that often are going to sneak up on us in pregnancy, and we need to be acutely aware of how to manage them. How did those pregnant ladies present in these studies? So, fortunately for us, 93% of them were symptomatic, but be aware about 7.5 or 8% of these patients are going to be asymptomatic. So when you're on labor and delivery, when you have patients laboring for 24 hours, 36 hours, if you're in a country that has the capabilities of screening those patients, we might start to think about plans to implement. How do we screen all patients that are coming on labor and delivery and actually having a baby so we can be prepared to appropriately cohort those patients? How do pregnant ladies present? Most of them present with a fever. A lot of them have a cough. Only a few of them, though, less than 10%, develop dyspnea, diarrhea, sore throat, or any body aches. Fever and cough are the unique characteristics of this disease, and it tends to be a dry, non-productive cough, exactly what our first pregnant patient had when she presented to us in about the beginning of March. What other features can they show? On chest X or chest CT, they show that ground glass appearance, 82%. Again, these important terms here. I'll encourage you that I don't think chest CT is actually necessary to make this diagnosis, as I told you. Yes, you want to maybe evaluate that they have a viral pneumonia, make sure that they don't have any other overgrowth of obvious bacterial pneumonia, but I think that could easily be accomplished by a shielded chest x-ray. You could also consider doing lung ultrasound. There's a variety of papers written about that that you could find on PubMed as well. There's some lab abnormalities to note as well. D-dimer elevated in 22% of patients. I told you about lymphopenia or a low white count. This is the trick in obstetrics that we have to pay attention to. A fair percentage, 5% of these patients are going to have elevated LFTs. And that's because viruses cause hepatitis. Fortunately, it's not happening to a lot, but I know OBs, midwives that have come to me and consulted me for patients that are very concerned about a patient having coronavirus, but they simply because they have elevated liver enzymes. Think about what in your mind would be the most likely cause of a pregnant patient that's term who has elevated liver enzymes. It's not going to be coronavirus. It's going to be preeclampsia. Preeclampsia, high blood pressure, elevated liver enzymes. We have to think about common things first. Don't get obsessed with COVID-19. We need to be aware of it, but don't solely think that every single patient around the labor and delivery ward around Europe's OB office has issues with COVID-19, because the vast majority are not going to. Common symptoms, common problems of pregnancy are still going to present. We need to be complete obstetrician gynecologists when we're taking care of patients. How do these patients do? So, interestingly, only 4% of them got admitted to ICU, so that's reassuring as well. But if they do go to the ICU, a third of them require ventilatory support. We need to be fully aware of that scenario as well. If patients that are pregnant get COVID, if they get admitted to the hospital, if they start to have respiratory difficulties, we need to be communicating with our intensivists, our colleagues in the critical care scenario, because a third of them are going to need ventilatory support when they are admitted to the ICU. Unfortunately, there are more reported deaths to date, but these numbers are extremely small. The rate of death was about 0.3% in pregnant women in this study of 385 patients. How did these patients deliver? So 252 reported mode of delivery during the study. 30.6% delivered vaginally. The majority, 70%, delivered by C-section. This is primarily driven by data from China, and I don't fully understand why, other than assuming that there was a desire to expedite delivery in these patients so that we could concentrate on the mother and not have to worry about the pregnancy. So there is a higher rate of cesarean section. My presumption is that that's not always related to the way that these patients are laboring or to the virus, but very likely may be dominated and driven by what we're doing as obstetricians. Unfortunately, there is a good chance of delivering at term, but there is an association with an increased preterm birth rate of about 15%. How did the babies do? So we're still pretty confident that there is very limited to no vertical transmission. Yes, in 256 newborns, there were 4 that were diagnosed as COVID positive. There were 2 stillbirths and a neonatal death as well due to antepartum hemorrhage, not related typically to the viral issue. But these COVID positives, 1.6%, very low probability that the infant that is immediately a person under investigation is actually going to be positive. In this study, all of these patients, all the infants had positive RT-PCR testing and had mild infections. They recovered and they were discharged home. Interestingly, when they evaluated cord blood, placental samples, and amniotic fluid, every one of those was negative. And that'll be important to talk about when we think about how we should be laboring these patients. And they also evaluated breast milk samples. And we have yet to identify COVID within breast milk. And so we really need to be encouraging patients, particularly globally. Breastfeeding is critically important for moms and newborn babies and is compatible if the pregnant patient has COVID-19. Here's how this study was driven a bit by China's data. This case series from China, 154 of the patients came from China. You can see the Netherlands also contributed a number of 107 in this study as well. Let's talk a little bit about COVID-19 and how we should work in our obstetric practice. How do I manage my office? What should I be doing to address the issues as people come and go in and out of my office? How do I practice safely? How do I keep patients safe? So amazingly, there's just tremendous number of resources. You can find websites everywhere. These are some of my favorites. The Society for Maternal Fetal Medicine, the International Society of Ultrasound and OBGYN, the American College of Obstetricians and Gynecologists, and the American Journal of OBGYN has a really great 2 links here, Coronavirus Guidance and Coronavirus Guidance AJOG MFM, which immediately link you to all freely downloadable context and content about coronavirus. How do we protect our OB practice? Unfortunately, the best option at this time is prevention. We don't have a treatment. Yes, you've heard of remdesivir, used in very select people, not compatible with pregnancy currently, nor studied yet. We have no vaccine. We have a lot of developments about vaccine, but likely will not have a vaccine for at least 6 to 12 months. We need to avoid social gathering, traveling, and huge social events. I'm as much of a world traveler. I love to get out and travel. It's killing me every day slowly, but this is unfortunately the best prevention in public health. We've heard so much about this term. I've never heard the word social distancing, and I probably don't ever want to hear about it again, but it's so important to flatten the curve. You need to stay at least 6 feet away because of that study showing that we can just aerosolize this virus, and the farther you get away from the viral particles, the less likely you're going to get that critical 1,000 viral particles to actually obtain the infection. And there's clear data in numerous public health studies that show that this is an effective way to halt the spread of a disease. And I know you've all seen this graph. If we don't protect ourselves, we have a rapid rise. We overwhelm our healthcare systems. And if we socially distance, wash our hands, we can definitely flatten the curve and be very, very busy with this particular disease process in our hospitals, but we'll have enough ventilators, enough ICU beds to care for patients. Where did this come from, this social distancing phenomenon? So we've heard about the 1918 influenza pandemic, 50 to 100 million deaths worldwide. In the United States, we had 500,000. And we studied this in the United States, and we found that in Philadelphia, where they did not socially distance, you had a massive and rapid spike. But in St. Louis, where they took aggressive social distance and public health measures to keep individuals away from other individuals, they had a markedly less steep death rate and a flattened epidemic curve. So we know this is possible. It's not pleasant. I don't think anybody loves giving lectures over computers. I'd much rather be talking to you in a big conference room, be able to shake your hands and interact with you and talk and answer questions, but this is the best we have right now, and we have to manage and deal with it. And this is why. This is the study you want to point out to patients. You want to be St. Louis. You don't want to be Philadelphia. You want to flatten your curves in your countries. How can we do this in our office? What should your office plan look like? So we need to socially distance in the office too. You can't socially distance in the public and then come into your office and work in really tight spaces. Computers need to be spaced out. We need to adopt much more stringent cleaning surfaces on a regular basis, using hand sanitizer on a regular basis, doing virtual meetings like this, huddling virtually, not having in-person meetings at all in all of our offices, despite the fact that we're there. And something we took up very significantly, we need to be screening patients before their visits. They hopefully should be checking in from the parking lot. We should be talking to them about what's going on with them. Are they ill? Have they had a temperature? Have they had contact with sick people? What kind of job do they do? Where do they live? Temperature checks, as I told you, 99% in the initial study had a fever. So now we're all getting temperature evaluated prior to entry into any facility. And we should be delaying appointments if, when you've screened them positive, they should be sent home, sent to get testing, and we should try our best to delay the appointment if they're COVID positive, or until they have a negative COVID test. I read this article in the New Yorker in March 21st. Atul Gawande is a favorite author of mine. He's written numerous New York Times bestseller books. He talked to his colleagues in Asia. We all live in the same world. We have to work together. We're all after the same goal: health, success, healthy families, and good care for all the people we take care of. And what was found in Asia, and particularly in China when this started, was that if healthcare workers wore surgical masks and gloves for every patient encounter, they had markedly less infection in healthcare workers. There is a significantly slow adoption to this in the United States. I witnessed it in my own hospital facility. As soon as I read this article, I asked all of my staff to start wearing surgical masks, gloves, and eye protection for every single patient encounter, whether you're a secretary, a medical assistant, sonographer, or a doctor. This, I think, dramatically helped us avoid any infection. And if you're facing this currently in a plateau, if your country or locale, city you're in is during a surge or in the end of this, we need to make sure we're significantly regimented about wearing masks, eye protection, and gloves with every single patient. And if for some reason, with all your screening efforts, somebody gets into your office that has symptoms, isolate them, then put on more additional PPE that's necessary to help protect these from becoming infected. There's also a new way that we can manage OB outpatients. We can shorten their prenatal care. We don't have to see the patient every 2 weeks, every 4 weeks. We could maybe stretch that out, maybe collaborate with other people they're seeing. A lot of our patients in the United States see a midwife, a family practice doctor, an OB, and then they also come and see me as a maternal fetal medicine specialist. So we can shorten our visits. We can join them together. We can do telehealth visits. This is one article by Daughters Katz in the American Journal of Perinatology, published in April. Excellent article, just giving you an example of the way you can kind of compress your prenatal schedule. They say that we should diminish, if you have no medical complications, characterize them as low-risk pregnancies. If they're low risk and they need extra ultrasounds like twins, if they're very complicated like type 1 diabetes, then obviously we may need to see them more. But we need to think and strategize differently. They don't all need to be in person. A lot of this could be done via telemedicine. Defer prenatal visits until they're outside of their infectious window. So if you diagnose that COVID positive patient, don't see them in your clinic. They don't necessarily need to be seen immediately. Our first patient we took care of, taught us so many lessons about this. We waited until she had 2 negative nasopharyngeal swabs before she was invited back into the office. Fortunately, she was around 18 weeks when she presented. She had an ultrasound. If there's something essential that needs to be done, you must wear appropriate PPE, definitely limit staph exposure. Hopefully you're reading ultrasounds remotely, and I'd really encourage, and I'd like to show you later, a little bit about how you can actually use telemedicine if a physical exam is not indicated to communicate with these people so that you don't have to expose yourself unnecessarily to coronavirus as well. When these patients recover, we definitely want to be assessing their fetal growth, provide routine prenatal care, and importantly, A lot of patients around the globe use low-dose aspirin for risk reduction of preeclampsia. Make sure they stay on it. As I told you earlier, preeclampsia is much more likely to show up for these pregnant patients, and coronavirus is not affected by low-dose aspirin. We want to delay their delivery until they're non-infectious if possible, at least 10 to 14 days, ideally with negative testing, if you can do that within your country. And then induce the patient, then deliver them. And some people are actually talking about don't put staples in because they need to be removed several days later. Use a subcuticular suture so that can slowly heal and the patient doesn't have to return for that postpartum 1 or 2 week post-op check. And they're encouraging us to do all telemedicine postpartum visits for any patient for sure that has a COVID positive test, but I think that this could also be done for nearly all pregnant patients. So that's kind of a bit about outpatient management of the OB patient. Let's move into the hospital and talk a little bit about kind of the transition to how we see these people and manage them in the inpatient setting. And these are, again, pregnant ladies that we're taking care of. So if you look at the National Institute of Health, there's 5 kind of complex diagnosed characteristics and definitions for COVID: asymptomatic, mild, moderate, severe, critical illness. I personally kind of like this: mild, severe, and critical by Wu in JAMA 2020. That was published right after this started to hit the global front back in February. Mild is no or mild symptoms. The patient has a fever, she's fatigued, she has a cough. Those are kind of the most common as I talk to you. Maybe they have some other less common symptoms of COVID-19, but that would be considered a mild infection. If they start to develop tachypnea, elevated respiratory rate, their oxygen sats start to drop, particularly under 93, 92, 89% on room air, that starts to be a severe infection. Or on chest x-ray or maybe CT, again, I'd really encourage you to use chest x-ray or lung ultrasound to consider evaluating the lung effect of COVID-19. If there's greater than 50% lung involvement, that also is characterized as severe infection. And critical, as you know, respiratory failure, multi-organ dysfunction, shock, and moving towards intubation and significant critical intensive care. In the hospital, again, all healthcare workers, nurses, secretaries, front desk staff, surgical scrub techs, janitorial services, all patients, all healthcare workers that are interacting with COVID positive patients, or really any patient, should be wearing a surgical mask, gloves, and eye protection. Cannot emphasize this enough. Simple protection with a surgical mask, some eye protection like you would wear if you're cutting some wood or doing a project at home so you don't get splinters in your eye. We want to make sure that we're wearing that basic PPE at all times when we're in and out of our hospital. And if you have any patient that has symptoms known as a PUI or a true positive COVID patient, this is when you need to wear your N95, face shield, and don and doff appropriately all of the gear that we need to protect ourselves, as that is a significantly high chance of exposure. And I'd really encourage you to be an advocate for your staff and patients. You have seen an incredible global shortage of supplies for PPE, and unfortunately, we need to demand as healthcare providers this for our staff and our patients. It's critically important, and we should never be in a scenario again where we don't have this particular life-saving gear. Who should we be testing in the hospital? The Centers for Disease Control criteria for priority 1 testing is any hospitalized patient with symptoms. So if you have a pregnant patient who has a fever or a new cough or a new shortness of breath, they're absolutely priority 1 and should for certain be tested. Our hospital in New Mexico in Albuquerque is now testing every single hospital admission, symptomatic and asymptomatic. And if that testing is available, I would certainly encourage you to get to that point in your facilities. Who should we, again, similar to non-pregnant, this positive RT-PCR confirms the diagnosis. Bear in mind, though, similar to influenza swabs, similar to any test, there's always the chance of a false negative. False negative rates of this RT-PCR may be as high as 20 to 30%. So if you have a high suspicion that patient has a fever, 100.2, 101.0, has a dry cough, and that first nasal swab is negative, I would strongly encourage you to still consider that patient a person under investigation. Repeat the test. Consider doing a chest x-ray. False negatives are common. It has to do with the prevalence in your local communities. It has to do with the specimen type. If you're doing oropharyngeal, much more likely to get a false negative. Nasopharyngeal is the specimen type you want. The quality of the specimen. If you put the nasopharyngeal swab only in for 1 centimeter, you're just swabbing the little nostril. You're not swabbing the nasopharynx. It needs to go all the way back. It is going to elicit a cough in the patient. You need to wear face protection when you're swabbing these individuals. That has to do with the quality of the specimen. And then again, duration of the illness at the testing. If the patient shows up on day 7 or 8, she may not have a positive nasopharyngeal swab. It likely was more positive early on in her illness. Here's a little diagram, very nice article from Ashoka in the American Journal of Obstetrics and Gynecology in 2020, care of the pregnant woman with COVID-19 and labor and delivery. COVID-19 suspected pregnant patient. Get your RT-PCR. If it's negative and that patient has symptoms, particularly fever, cough, shortness of breath, do chest imaging. If it's positive, for certain, repeat that RT-PCR. And if they have a confirmed positive, then we move on to management of that COVID-positive pregnant patient. I can't emphasize enough to you how important there are many individuals. This is a team approach to care for these patients. Particularly at any critical care obstetric patient, you require the OB, the pediatrician or the neonatal intensive care unit doctor, the anesthesia doctor, incredibly important in this particular COVID-19 scenario, because when these patients develop respiratory compromise, it happens extremely rapidly. Your nursing staff, your hospitalist staff, your intensivist critical care staff, where you're going to need to transfer the patient if they need to be ventilated. All of this entire gigantic team is required for that COVID-positive patient. Maybe it's not all simultaneously, but I certainly, if I had a COVID-positive patient on my unit, and when we have our next and subsequent ones, we're notifying all of these individuals, making them aware that we have a patient that may decompensate quickly over time. Pay attention to your patients. Maternal oxygenation, incredibly important. As we know, pregnant women are more at risk for ARDS. Fortunately, most pregnant women have had mild illness, but if you have a severely ill pregnant patient, be very aware of adult respiratory distress syndrome. Make sure their O2 on room air or with oxygen support is at 95% or above, and have a low threshold if we start to see downtrending of that respiratory oxygen status for mechanical ventilation, because very likely that's where you're headed. Put the patients on some venous thromboembolism prophylaxis. I'd really encourage you to use heparin 10,000 units sub-Q twice a day. That tends to be preferred in any setting. It's inexpensive, particularly if you're close to delivery in the patient's term. It has a short half-life, so the patient could achieve regional anesthesia or have a cesarean section without any complications of bleeding. If she's like my patient, who was 18 weeks upon initial diagnosis, we put her on low molecular weight heparin, and that's given 30 or 40 milligrams sub-Q once a day. You want to be using this in a patient who's unlikely to be delivered, unlikely to need any operation, or is postpartum. As I told you with that multidisciplinary team, you got to have clear, concise, and commonly frequent communication with all of your team. This is a great article, Expert Consensus for Managing Pregnant Women and Neonates Born to Mothers with Suspected or Confirmed Novel COVID-19 Infection. Put your patients on antibiotics as well, because commonly these people will also have a viral and bacterial pneumonia. So broad spectrum antibiotics is recommended for these patients. Do conservative IV fluids, don't volume overload them. And if they develop acute renal failure, of course we're going to need hemodialysis as well. Here's again a nice algorithm from Ashoka. You have that patient who's in labor, she has COVID positive diagnosis, her SpO2 starts to not stay above 93%, so she becomes hypotensive, she's moving towards shock. We want to get the intensivist involved, get an echocardiogram, put her on pressors, and you can see a variety of different paths that these patients could take you on. and we need to be fully aware and fully prepared for that. There are a variety of things we do in obstetrics that are unique. We give patients betamethasone, we give patients magnesium sulfate, we give them low-dose aspirin, all kinds of meds that are not common for non-pregnant individuals. Sadly, there's been some studies that show that in not pregnant people, systemic steroids actually worsen the outcome in patients that have COVID. So that's made us question, should we be giving antenatal corticosteroids to preterm pregnant women when they're in labor early or they break their bag of water early? But I will strongly encourage you, because of tremendous benefits to the preterm infant, all of our professional societies, SMFM, ACOG, are recommending that between 24 and 34 weeks, if you have a patient that is in imminent preterm labor, has preeclampsia, needs delivery, we need to be exposing them to betamethasone 48 hours prior to delivery for the benefit of that preterm fetus. We also want to keep using low-dose aspirin. COVID has no issue, there is no problem with low-dose aspirin in the setting of coronavirus, and it is still extremely helpful for the prevention of preeclampsia. Non-steroidal anti-inflammatories, there is some concern about ibuprofen, particularly in young individuals, but that's tend to be not the issue, and so non-steroidals also can be used. When should we deliver that positive coronavirus patient? The COVID-19 infection itself is not an indication for delivery. Most patients are going to present preterm. Most are going to have a mild illness, so we have no reason to deliver them early. Ideally, when they get better, document that they have a negative test result so no one fears taking care of them, and then we can lift their transmission-based isolation precautions and allow them to have a normal pregnancy with routine prenatal care. I'll say, though, that COVID-19 might be an indication for delivery if your patient has a definition of COVID which is severe or critical. This is when you want to have a team approach, conversation, discussion, and a plan. The management is going to be individualized. Unfortunately, if this presents extremely early, if it had presented in my patient at 18 weeks, had she been critically ill, needed to be ventilated, I would have recommended that we deliver the fetus, induce labor, which very likely would have been life-saving for the mother. And unfortunately, in that setting anyways, there's a huge risk of perinatal death. At 24 to 34 weeks, we need to assess both the safety of the mom and the baby, and ideally prolong the pregnancy as long as possible, trying to get to that 34-week mark. And this depends globally on what your neonatal intensive care unit care acuity is. I think in the United States, I would personally be starting to think about delivery even after 32 weeks if a patient started to deteriorate with coronavirus. And after 34 weeks, there's a huge success rate for survival of that neonate. So I'd really encourage you to consider delivery after 34 weeks in any patient that has coronavirus, because that way you can focus directly on the mother, and the baby has a huge and very high rate of intact survival. What about the mode of delivery? How should we be delivering these people? So although 70% in prior studies have seemingly had a cesarean section, this is not an indication for C-section. They can have a vaginal delivery, reserve C-section for routine indications. And if your hospital and your locale have the capabilities of doing lots of COVID testing, I'd really encourage you to do testing before delivery on all patients. Why? It helps cohort them. It helps decrease anxiety for the patient, helps decrease concern amongst staff members, and helps us to not have to maybe separate or do a lot of special care for that infant born to a COVID positive mom. If we know that the mother is COVID negative, we have a lot more confidence on how to manage that mother-baby pair. Anesthesia should be the same. Regional anesthesia helps reduce pain. It decreases heavy breathing. I told you heavy breathing sends out lots of viral particles. Maybe epidural anesthesia may actually reduce the viral spread, and then it's always available there while you're in labor if that patient needs a cesarean section. In the United States, we use a lot of nitrous oxide as a form of analgesia. We should definitely discontinue that due to concerns about how the machines are clean and also how it aerosolizes the virus. Our labor management, checking a patient in active labor or looking for cervical dilation every couple hours, that does not change. We need to labor patients exactly the same as we labor any other patient, infected or not, with COVID-19. And SARS-CoV-2, to be very confident, is not detected in vaginal secretions or amniotic fluid. So don't be afraid to break the bag of water or place an internal fetal heart rate monitor. These things are all normal in parts and are safe in the process of laboring a patient with COVID-19. Get rid of oxygen. It's not useful. There's no scientific proven benefit that helps during labor resuscitation. Oxygen therapy, particularly through a mask, aerosolizes the virus, increases our exposure as healthcare workers, and we should not delay pushing in the second stage. Patients should immediately start pushing when they are 10 centimeters dilated. Important. A lot of these patients are asymptomatic, up to 7 to 10%. 15% in one New York study of your pregnant patients are going to be COVID positive but have no symptoms. When they're in labor or when they're postpartum, if they develop a fever, think about coronavirus. This is the time to move that diagnosis into your thought process. Of 12 asymptomatic patients that were identified on universal, everyone on L&D got tested. Interestingly, 2/3 of those asymptomatic patients developed a fever, 5 during labor and 3 postpartum. So it's not uncommon. You very likely will see this. It's going to be a not sick individual. She's going to develop a fever. Test her and start treating her as if you're thinking about COVID-19. Do pulse oximetry, a lot of surveillance on the postpartum unit. Try to get rid of all your pregnant patients quickly on postpartum day 1, 12 to 24 hours after vaginal delivery, and within 24 to 48 hours after a cesarean section. If your mother has COVID-19, by nature, the infant is a person under investigation. We should isolate that patient, that infant, from any other infant. And we should be very careful in how we handle that infant between different individuals in our facilities. Test the infant as soon as possible after delivery, ideally, and much more commonly less than 24 hours. They need a throat and a nasopharyngeal swab, and then we should be repeating that prior to discharge. The mom with COVID-19, if the infant is negative, should practice social distancing from her newborn. I know that seems difficult. She needs to wear a face mask and practice hand hygiene anytime she's interacting with her newborn to try to avoid transmission of the virus to her newborn baby. I'll reiterate, there's no study to date that's demonstrated that SARS-CoV-2 is identified in breast milk, so we need to be telling pregnant women to breastfeed. It's a passive source of antibodies for all kinds of viral infections, and I'm certain that it probably works to help protect that infant, passing IgG antibodies to the newborn. There are 2 worldwide registries, one in the United States, this priority study in the University of California, San Francisco, another one, the International Registry of Coronavirus, which is a global study. Please encourage your patients to think about becoming enrolled in one of these studies if you identify COVID-positive patients. I'd like to take the last little bit here, and then we'll get to questions and answers, to talk to you about our own experience, my practice, Perinatal Associates in New Mexico's experience with COVID-19. So March 8th, early in March, this started to hit the United States. The first case was in Seattle, Washington. We started to develop a COVID screening questionnaire. We posted signage at every one of our entrances. We started screening every single patient. And we initially told them, we're not going to do anything for you. We'll just send you to urgent care or the emergency room if you're ill. And then we delayed the appointment until they told us that somebody else had done appropriate testing on them and they were negative. We decided that maybe wasn't the best thing because patients don't like to go to the ER, don't like to go to urgent care, and then we're not taking care of our patients. So we actually edited that screening questionnaire. We actually said, we'll order the flu and we'll order the COVID testing on you. As we start to get closer to September, when flu season is going to be upon the United States and the rest of the globe, make sure when these patients are of concern, you give them a flu antiviral and then do their COVID testing. This empowers you as a practice to look at and feel like you're taking the best possible care of your patients, and it helps allow you to stay safe, not bringing in patients that are positive and documenting that they're negative before they enter your office. On March 17th, we again added our screening process. We started to do telemedicine visits on every one of them if they complained of symptoms. Again, we are ordering testing, and we again delayed all their appointments. We developed a COVID outpatient clinic designated specifically with appropriate PPE, reverse airflow, so that if we had positive patients that we needed to see in the outpatient setting, they would go to a single clinic location. And we also started to develop a brand new check-in process. There's no more coming into the waiting room and waiting with 16 people in the waiting room. They now text us when they arrive in the parking lot. We re-screen them, ask them the exact same questions we asked them 2 or 3 days ago for their pre-screening. Because you know what? They can get sick rapidly within 2 days is the shortest incubation time. And we had done all of that before March 23rd when our governor finally ordered a stay-at-home order. This was our initial do not enter stop sign presented on every one of our offices, phone numbers so the patients could contact us and not enter our offices. Here's some of the questionnaires that we started with. This was the first one on the left side of your screen and the second on the right. You need to start asking patients, have you had testing for COVID-19? The testing is much more widely available globally. So don't just ask them if they're sick. Maybe somebody else ordered COVID testing. They think they're perfectly fine and they're just going to show up in your office. So be aware of who's there. And so just be aware that you need to change your questionnaires. Have to tell your staff what you want to do. And so we had a lot of designated protocols. And I ultimately started with one file in a COVID-19 file on my computer and now have over several hundred developing these protocols and processes in our office to make sure we're taking care of our staff and our patients. Here's the news when our governor in the state of New Mexico issued our stay-at-home order. Fortunately, this is now expired. We're entering phase 1 of our reopening. We'll pray that on May 15th, this is beginning to not have an effect on a resurgence in our community. You can be a leader for your country and your state and your region and where you're working. Share your protocols. Announce them to all of your referring providers. Help teach other people how you're doing this. We started to do telemedicine visits for a lot more patients. We sent a guide for clinical management to every one of the OB providers that we work with. We take over 400 maternal transports by helicopter and air flight into our facilities, so we provided a guideline on how to do that safely. And then we started to look at how we could make our office even more efficient. We don't want to spend 20 minutes or 30 minutes with every single patient. Could we make that faster? So we started to evaluate doing abbreviated ultrasound examinations that the American Institute of Ultrasound and Medicine, ISWAG, had been talking and advocating about. Here's just an example letter of how we were emailing and referring to referring providers, being a leader and showing them what we were doing within our practice. Helping them with a variety of guides for clinical management, showing them all of these little hyperlinks that they can easily access because there's so much information. This is giving them concise, very good, interactive information for their practice. Let's talk a little bit about abbreviated ultrasound exams. And then we'll get close to closing and we'll move to questions and answers. I'm a huge fan of protocolizing ultrasound and trying to do things efficiently, the same exam on every single patient. So when a patient comes in for a first trimester exam or a second trimester exam, we're always doing the same images, the same anatomic evaluation of that pregnant patient. And you can see that we use designated electronic special protocols built into our Philips ultrasound systems using a tool called Smart Exam. And we have a lot of these protocols. You can see here there's 5 columns, there's 5 different exams per row. So we got 25 different protocols in our practice we use, and we can use this with just a touch of a button on the touchscreen interface. But you can see here we started to put in here protocols for coronavirus. How can we make our COVID first trimester protocol faster? How can we make our targeted genetic detailed anatomic evaluation more quick? Try to get the patient out of the office. So we started to input different protocols. Instead of taking hundreds of individuals' pictures, we're now using sweeps, sagittal and transverse sweeps, head to toe of the fetus, sweeping up from the heart, stomach to the 3-vessel trachea view, sweeping left to right, getting all of the anatomy in a nice, slow, methodical sweep, cine loops for 10, 20, 30 seconds to acquire all the anatomy, look at the fetus, take your 3 crown rump length measurements, look for any abnormality and document stomach, bladder, and cord insertion. And there's our COVID first trimester protocol. We also did this for the second trimester. Again, sweep through the entire uterus. Look for any adnexal uterine pathology. Sweep the whole fetus from the head to toe. Look at the brain anatomy as you're sweeping. Your brain's naturally doing this, but you're documenting it with cine loops. You're taking the core basic measurements that are necessary for estimated fetal weight. You're doing a single maximum vertical pocket, no more quad pockets, just a rapid MVP, should be between 2 and 8 centimeters. And then take a variety of but limited 2D still images. And again, here's an example of how we're using that smart exam. It's guiding us, telling us to take each of our pictures, not to forget things, and it's automatically annotating things. We've looked at this before. I told you I'm a big fan of ultrasound protocols, and the reason I like protocols is because I've been able to demonstrate that they save us time. And there's no greater scenario where we would want to save time than in a pandemic where you might be interacting with an asymptomatic patient who has coronavirus. You want to diminish as much patient time as you need in that exam room, and protocols might help you. We published a paper in 2016 called Obstetric Ultrasound Efficiency and Accuracy using a protocol-based exam. Again, this used smart exam. It allows us to annotate things automatically, turn on different modes automatically, M mode, color, Doppler, pulse wave, just diminishing the number of buttons you have to push. It gives you this beautiful visible checklist for our COVID anatomy. It helps us process through, not forget things, but quickly document anatomy in a patient and then dismiss them from the office. In our study in 2016, we actually saved almost 10 minutes per exam. We decreased our exam time from a half an hour down to about 20 minutes. And I can tell you, I will present this at a later date, but I can tell you that the sweep, these 3 COVID positive patient algorithm protocols that we've designed also are saving us more time. And we're doing an effective job in this pandemic to limit our exposure, our sonographer's exposure to any person under investigation or a positive COVID patient. I really believe in protocol-based ultrasound exams, and I really, really would encourage you to try them in your practice. What about telemedicine? There's so much information about telemedicine, and this is what I'll conclude with. Telemedicine and COVID-19, really the pandemic of COVID-19, I think will change our medical landscape for a long period of time. People have said that telehealth is an approach to optimize our care. I think the biggest issue is it helps mitigate our risk. Telemedicine has been identified as a mechanism to overcome obstacles during disasters. And this study by Aziz in the American Journal of Perinatology, just published in April, says that we could eliminate about half of in-person visits if we follow this protocol. So do virtual or telemedicine prenatal care for your intake, your 14 to 17 week visit, 23, 26, kind of these non-important visits where we're not doing lab tests. In-person needs to be at 11 to 13 weeks when they're getting their nuchal translucency, 18 to 22 weeks when they're getting their mid-trimester anatomy exam by ultrasound, 28 weeks in-person when they're getting their glucose tolerance tests and their CBC or blood count, 36 weeks when they're getting their Group B strep testing, and of course near delivery at 39 to 40 weeks. What about for us? My practice, we do 25,000 ultrasounds a year. We do 15,000 antenatal BPP tests a year. I mean, how do I do ultrasound and provide maternal fetal medicine care? Because an ultrasound exam requires an in-person visit. Is there any way as an MFM or maybe an OB physician that does a lot of ultrasound in their practice, is there a way we could decrease our use of PPE? Could we conserve our own supply of PPE? Because as I told you, there's a global shortage. How could we possibly do this? So interestingly, our practice, Perinatal Associates, was actually conducting a pre-approval FDA study of a new telemedicine solution called Collaboration Live. And it's produced by Philips. And we were looking at this FDA pre-approval study between January and February of 2020, which is exactly when the coronavirus pandemic started. So we were completing this study, evaluating if the tool worked, and we started to recognize that maybe we could actually use this novel telemedicine device to actually interact with our patients. Yes, the sonographer has to do the ultrasound exam, but if I could use the ultrasound machine while the patient's already sitting there and I don't have to walk in the room, I don't have to put on a bunch of gear for a PUI or a COVID positive patient, maybe that would be helpful. So this system utilizes a desktop application called Reax, And you load that system on your laptop, and you're able to contact a variety of different individuals, and they can contact you by text. You can text into your sonographers. So my sonographer, when they're done with their ultrasound exam, they use their smart exam, so they're doing a rapid exam on that COVID positive suspected patient or the true COVID positive patient. They tell me they're ready. They step out of the room. Patient stays in the room. I call to the ultrasound machine, and it looks something like this. This green dot comes up, and the patient answers. And then I'm able, with my, be it a tablet, actually able to I now have control of the Rio Rancho. That's one of our offices in suburban New Mexico. I now have control of the ultrasound system, in total communication with the system as well. Now, granted, I can't operate the system, but I can show the patient all of her images. I can manipulate 3D volumes. If the sonographer was still in the room, I can actually take images, direct the sonographer to look at fetal anomalies, again, limiting your exposure to your physician staff. I only have 4 MFM doctors in our practice. If we lose 1 or 2 of us to coronavirus, significant diminished capacity to continue to care for our patients. So this Philips Collaboration Live system allows us a new way to enter the ultrasound room without actually physically entering the room. And this is what it looks like. I'm physically visible to the patient on the screen. The sonographer, obviously she would be wearing a mask during coronavirus. This was not during a patient of concern. And I'm able to look at the pregnancy, review all the images. I can manipulate the touchscreen interface here, taking any kind of pictures I need, not having to enter the room and have to expose myself or others to the virus. And had the sonographer left, I could simply communicate with the patient directly through this, do the consultation. Any circumstance that doesn't require a physical exam, this new tool, tremendously helpful in the world of telemedicine. Our practice now has converted all of the following to simple, easy telemedicine visits. They're not conducted in person anymore. All genetic counseling visits, actually our genetic counselors operate from their homes now. All of that is done via telemedicine. All diabetes management, pregnancy done by telemedicine. Any patient who desires a pre-pregnancy visit, telemedicine. Any pre-appointment screening where there's a suspicion of COVID-19, asymptomatic exposure that they needs testing, all done by telemedicine. If you happen to be a person under investigation in the outpatient or inpatient setting, telemedicine. And if you have COVID-19 and you're positive, we're ideally trying to confine that to telemedicine in all circumstances. We use a lot of different multiple modalities, FaceTime, Skype, whatever's available in telemedicine to make this happen. But Philips Collaboration Live is yet another way. It allows us actually to telemedicine into the room over the ultrasound system. And it was the first time we ever had done this during a COVID-19 pandemic. I told you I was a big fan of Atul Gawande. I'm going to conclude here. I really appreciate all your attention. We're obsessed in medicine with having great components, the best drugs, the best devices, the best specialists, but we really pay little attention on how to make them fit together well. If at any time in your practice of medicine you need to think about how you're practicing from a physical standpoint, getting people in and out of your offices, how you conduct your exams, how efficiently, how you're communicating with people, this is the time to make things fit together well. And I'd really encourage you to take some of the ideas that we had, our own success in our practice, feel free to use them in your own. Whether you like it or not, we're all involved in this pandemic and the fight against it. COVID-19 has or will affect each and every one of us. I really encourage you to become and maintain being an active learner and a leader as a physician and a sonographer and a healthcare professional. Communicate with your practice staff, your hospital administration frequently. Educate and train and discuss commonly, frequently with your staff, both in the outpatient and inpatient setting. As I showed you just earlier, you have to embrace telemedicine. It's here to stay in medicine for years to come. Think about your processes, refine them, borrow from others, steal, talk to me. I'd be happy to share anything that we've done with you. And always at the end of the day, make sure you're doing your absolute best to do what's right for the patient. You'll never go wrong. I really appreciate the time that you spent with us around the globe. I'd be happy to answer any questions. This is a COVID-19 page from Philips, and I'll end there and move on to questions.
Thank you so much, Dr. Ruma. That was really comprehensive and a lot of information for everyone to digest and very helpful. If anyone has any questions, please don't hesitate to type them into the question and answer section, and I will read them out to Dr. Ruma. I do have a couple for you to start off with. The first one is regards to lung ultrasound. We know that ultrasound has been proven to be more sensitive than a chest x-ray, and obviously on a pregnant patient, lung ultrasound is going to be the way to go rather than doing CT or chest x-ray. Are you performing any lung ultrasounds in your practice routinely?
Personally, no, but I'll encourage the folks around the globe. Certainly, chest x-ray may not be available in your institution, and you're there looking at the patient with an obstetric ultrasound. I showed you why we're using Collaboration Live to telemedicine in the room. There's an article I'll recommend to you called Effectiveness of a Fast Lung Ultrasound Teaching Program for the OBGYN, and it's by Bon Senso. And so just look up that article. It's freely available as a way to learn about how to do this. There's a variety of characteristics on lung ultrasound. I am not a lung expert, but certainly I think that this is something that we could learn by this article has a nice link to some videos to educate yourself about that.
Great, thank you very much. The next question, we know there's a higher risk of patients developing clots having COVID. A lot of links to patients having pulmonary embolus. These patients are being managed with heparin and other blood thinners. Now, with the increased number of C-sections that are being done, is this presenting a higher risk to these patients of increased bleeding during C-section?
I would say no. Yeah, I would say no. We, unfortunately, pregnant women are at risk of venous thromboembolism via either DVT or pulmonary embolus. We're hypercoagulable. We have a hypercoagulable state just simply being pregnant. You add a virus, it affects the endothelium of the veins. We need to be anticoagulating these patients. I'd really encourage heparin. It's much cheaper than anticoagulation with enoxaparin. Heparin, 10,000 units sub-Q twice a day, is absolutely not going to alter any patient's bleeding time. I would encourage that dose, not any higher, and you'll not run into any trouble.
Thank you. Are there any other ultrasound findings that you have noticed in a patient who has COVID-19? A pregnant patient, obviously. Anything, fetal abnormalities, umbilical cord Doppler abnormalities, any other sort of abnormalities that you have noticed in these patients?
Fortunately, in our practice, not. I think in the setting of a severe infection, our patient, the first that we managed, and we've now had probably about 10 different patients in our practice. You learn from experience. These patients are losing a significant amount of weight. They are at definite risk from viral infection that maybe that alters the placental blood flow and contributes to growth restriction. So I would seriously encourage anyone taking care of a post-recovered coronavirus patient to do serial fetal growth surveillance, evaluate that patient in the third trimester, 32 to 36 weeks, make sure they have a growth evaluation by ultrasound because growth issues such as intrauterine growth restriction much more common in that type of patient.
Thank you. One more question. Are patients concerned, or do they express concern about other COVID patients being in your practice prior to them entering? How do you reassure them that you've taken the proper precautions with making sure everything's been sanitized and cleaned before they are entering the rooms?
Yeah. We have put that, you look at airlines advertising like crazy about their cleaning their cabins constantly. Reassuring the general population about disinfection is huge. We have it on our website. We have it on YouTube videos. We've been on TV talking about it. We tell the patients about it. We show the patients that we're doing it. And it's obvious when they walk in the room. The rooms are cleaned immediately after every single patient encounter. All bathrooms are cleaned after every single patient encounter. And that reason I showed you the Philips COVID-19 website is there's some unique ways to clean your ultrasound systems. Every piece of the ultrasound system needs to be cleaned, disinfected in between every patient. And if possible, the gel that we're using when we do ultrasound, if possible, maybe is best done in single packets per patient.
Yeah, makes sense. And sorry, I do have one more question that's come through. What is your patient's reaction being to using telemedicine and actually not seeing your patients and giving them a personal service that they're obviously being used to getting in your practice?
Yeah, so one of the greatest joys of being a doctor is human contact, interaction with the patient, visiting with them, laughing with them. For the patient that was our first coronavirus positive patient, she had absolutely every understanding in the world of why we were connecting with her via telemedicine. She knew absolutely that she was highly infectious, and she had really no interest in having any more people in her room to take care of her than necessary. Fortunately, all she required was oxygen support, IV hydration, so really limited nursing care and physician care was necessary. Talking to her about her pregnancy and the complications that could occur as an MFM, doing that over telemedicine was very, very useful. My experience in doing the pre-approval study for Philips about this new collaboration live telemedicine tool, all telemedicine takes learning about how do you communicate with people over a computer, over a visual link to them. I will tell you that with my experience now, I can get patients to laugh at my same jokes, interact in a warm fashion, smile, and have that human contact. Yes, you're not in the room, but the patient satisfaction is actually extremely high.
That's good to know. Thank you. On that note, thank you very much. I'll hand it back to Sen to close. If there are any final questions, doesn't look like it. Okay. Thank you so much, Dr. Ruma.
Okay. So, yeah, again, thank you so much, Dr. Ruma, for that very informative and interesting webinar topic. To all the participants, thank you for your time today. So this is Sen Castro, the Business Marketing Manager for OBGYN for Philips Asia Pacific. Thank you very much, and till the next webinar.